Dementia Researcher with a blogger narrating.
Small vessel disease, a quiet driver of dementia. Since moving to the University of Edinburgh, a large part of my research has shifted towards vascular dementia and small vessel disease. It is a natural progression for me after recent years focused on vascular neuropathology and dementia. I wanted to use this blog to introduce the topic to anyone who, like me not so long ago, may not have given it the attention it deserves. When we talk about dementia research, the conversation often gravitates towards amyloid and tau. These are the headline pathologies, the ones that attract the most funding and fill the most conference sessions. But there is another contributor to dementia that affects millions of people worldwide and arguably represents our best opportunity for prevention. Cerebral small vessel disease, or SVD, is the most important vascular contributor to cognitive decline and dementia. What is cerebral small vessel disease? SVD refers to a group of conditions that damage the small blood vessels deep within the brain. You cannot see these vessels on a standard scan, but what you can see are the consequences: white matter hyperintensities, lacunes, microbleeds, and enlarged perivascular spaces that are the hallmark imaging features that tell us something has gone wrong in the microvascular level. If you have ever looked at the brain MRI of someone over 65, chances are you have seen white matter hyperintensities. They are incredibly common in aging populations, and their presence increases with age, hypertension, diabetes, and smoking. From an epidemiological perspective, SVD is not a rare condition. It accounts for approximately 25% of all ischemic strokes and contributes to an estimated 45% of dementia cases globally. Those are not small numbers. Yet when we think of the landscape of dementia research, the proportion of attention SVD receives does not match the proportion of diseases it causes. Small vessel disease and vascular cognitive impairment. Vascular dementia is the second most common form of dementia after Alzheimer's disease. The World Stroke Organization's 2026 fact sheet reported that pure vascular dementia accounts for around 15% of all dementia cases, with mixed vascular and neurodegenerative pathology responsible for another 16%. Together, that represents approximately 17.6 million people worldwide. Under current trends, the global burden is projected to reach 42.7 million cases by 2050. SVD sits at the centre of this. It is the primary driver of vascular cognitive impairment and the most common pathological substrate underlying vascular dementia diagnoses. From population neuropathology studies, including work from the Cognitive Function Aging Studies in the UK that I was involved with at Newcastle, we know that vascular pathology is one of the most prevalent findings in the aging brain. Late-life dementia is rarely caused by a single pathology. Mixed disease is the norm, and SVD is frequently part of that mix. What is driving the damage? Recent research has advanced our understanding of the mechanisms through which SVD leads to cognitive decline. A comprehensive review by Marcus and colleagues in 2025 laid out the current understanding of SVD pathogenesis, identifying blood-brain barrier disruption, endothelial dysfunction, neuroinflammation, and impaired perivascular clearance as the central processes driving disease progression. Very recently, in a study by Lee and colleagues from 2026, showed that disruption of the blood-brain barrier within white matter hyperintensities was the strongest predictor of how much those lesions would expand over time. Disruption in the tissue surrounding existing lesions, the penumbra, was the best predictor of which patients would progress to worse disease. This is significant because it suggests we may be able to identify individuals at highest risk of cognitive decline before it happens, using imaging markers of blood-brain barrier integrity. Risk factors for small vessel disease are largely the same ones epidemiologists have been tracking for decades. Aging, hypertension, hyperglycemia, and smoking all increase levels of reactive oxygen species and pro-inflammatory cytokines, compromise vascular integrity, and ultimately damage the brain. These are modifiable risk factors, which bring us to perhaps the most important point: prevention and what comes next. The American Heart Association's 2025 scientific statement described vascular contributions to cognitive impairment and dementia as potentially the most preventable cause of clinically significant cognitive decline. That is a bold statement, but the evidence supports it. Intensive blood pressure lowering has been shown to reduce white matter hyperintensity progression and delay cognitive impairment. There is also emerging evidence that B vitamins can lower homocysteine and may slow white matter lesion progression. On the treatment side, there are currently no FDA-approved therapies specifically for vascular cognitive impairment. However, clinical trials are underway. Isosorbide mononitrate and citalopram, both modulators of endothelial function, have shown promise in reducing recurrent stroke, dependence, and cognitive impairment after lacunar stroke. Newer therapeutic approaches targeting neuroinflammation, oxidative stress, and endothelial dysfunction are also in development. From an epidemiological standpoint, the challenge now is translating what we know about risk factors into effective population-level prevention strategies. We have the knowledge. The question is whether we can implement it at scale to reduce the burden of SVD-related dementia in the decades ahead. That is a question I am looking forward to working on in my new role at Edinburgh. Why this matters. Small vessel disease is not a niche topic. It is a major contributor to dementia worldwide. It overlaps with and worsens Alzheimer's pathology, and it is driven by risk factors we already know how to target. If you are serious about reducing the global burden of dementia, giving small vessel disease the research attention and funding it warrants is not optional. It is essential.
Thank you for listening. Join the Dementia Research bloggers and share your own views.